Okay, so I'm now recording this presentation based on the deck of slides that I showed at the European Society of Neuroradiology annual meeting 2025 last week. And this presentation covers the RANO 2.0 criteria, the BT-RADS system, validation studies, and some tips on the clinical practice. So RANO criteria are a set of criteria to measure gliomas essentially on MRI scans, and then to define whether they are growing over time or shrinking over time as a result of the treatment. And the RANO 2.0 version, recently published, relatively recently, has a specific diagram to explain how these are put into practice. The RANO criteria are not primarily designed for the clinical practice. They're designed to provide standardized, reliable imaging endpoints for glioma clinical trials that are testing new medications in clinical trials for gliomas. And these endpoints are progression-free survival and objective response rate that have been shown to correlate with their overall survival. So that's why they are justified as surrogate endpoints for overall survival, specifically for trials that do not last long enough compared to meet the actual overall survival endpoint. Let's think about low-grade clinical trials like the INDIGO trials. But more in general, they provide complementary information in addition to overall survival for all glioblastoma clinical trials too. They are typically applied in the local RANO reads of multicenter clinical trials, but more importantly, in the centralized RANO reads after data centralization, and this is where all the PFS curves that we see in the articles come from. As a neuroradiologist, I think it's important to know these criteria in case you have to use them as a reader of a clinical trial, but also to import some concepts in the clinical practice, and why not for research applications. A first step to applying the RANO criteria is to know how to measure the tumors at each specific time point. Of course, you will have to repeat this step for all the time points of the patient that you're evaluating. And after you do this, you will have to, if you typically tabulate the results of percent growth or shrinkage for each time point, so that for each patient you can flag whether you see a response or a progression or stable disease at each time point. Again, you have to repeat this passage for all the patients of the clinical trial, and this is where the curves of PFS and objective response rate come from. Before you even measure, you have to know what to measure. So for contrast-enhancing tumors, you have to measure the contrast-enhancing component only according to RANO 2.0. For non-enhancing tumors, the non-enhancing component, unless a new enhancing component appears, but in that case, it's pretty much progressive disease or preliminary progression, obviously. And for cases where that we call mixed tumors, meaning that the lesion is mainly non-enhancing but has some small enhancing dots, then in that case, you consider target lesions both non-enhancing and enhancing components, and you track them separately for RANO purposes. It's important to understand that for a clinical trial that decides to adopt this variation of RANO 2.0, it has to be applied to all the gliomas in that clinical trial. So you cannot decide whether to apply the mixed tumor variation or the contrast enhancing variation at a patient specific level. It's all patients in a way or all patients in the other way. A cornerstone of RANO 2.0 is the concept of measurable disease. You call a measurable disease, you call a presence of measurable disease if there is at least a nodule of 1 by 1 by 1 in 3D imaging centimeters, or 1 by 1 centimeters on 2D imaging on two adjacent slices. It's important to understand that this is a binary variable, present or absent measurable disease, and this changes the way you handle the RANO evaluation. Only if there is presence of measurable disease, you can go ahead and quantify the tumor burden by multiplying the two diameters or directly using the tumor segmentations. Hopefully in the future, there's going to be more and more available AI segmentation. So this, I hope, will be the main road moving forward. But as of now, it's still important to assess preliminarily that there is measurable disease according to RANO 2.0, meaning 1 by 1 by 1, for instance, in 3D imaging, before we even proceed to quantify the segmentation in terms of volumes. This is very important because we don't want to be in a situation where there is like for instance, pericavitary enhancement after surgery that enhances, and that if you segment all of it, even makes up for, it makes I don't know, like several cc's of tumor, of enhancing tumor volume, and then you may start tracking that. But if there is no actual nodules that you can manually segment, it means there's no measurable disease. So this is a preliminary evaluation that you still have to do, even in case you're using segmentations. So let's move forward to this step where we tabulate and evaluate the numbers that you pulled for all time points. The full flow chart, it's kind of convoluted, but let's see at least a couple of main aspects. I do want to point out how the first thing that you have to check is whether there is or not, or there isn't measurable disease. So again, to reiterate the importance of the aspect. RANO 2.0 mandates some specific reference MRI scans that you have to compare to. Sometimes in the clinical practice, unfortunately, we just compare to the previews that we have or whatever we have. But for RANO 2.0, the response requires a shrinkage of at least 50% bidimensional or 65% volumetric compared to the baseline. So for instance, here there's shrinkage compared to baseline, we call response. Progressive disease, instead, it has to be at 25% in diameters or 40% in volumes compared to nadir, which is the smallest time point of the series. Again, very important. You're not just comparing to the previous, you're not just comparing to baseline. Here, there is a small growth compared to baseline, but it's a significant growth compared to nadir. It means that the tumor has started to grow again, and this is why we call this a progression. So we said the nadir is the smallest size observed on study, and the post-radiation baseline is used for gliomas that received radiation. So this is a RANO 2.0 novelty that comes from modified RANO, where we kind of disregard whatever happens before the post-radiation time point. We just start track and consider things after the radiation for tumors that do receive radiation, of course. Confirmation scans means that sometimes whatever you however you label a time point, is dependent on whether you can observe the same finding or consistent findings in the subsequent confirmation scans. So for response, confirmation scans are always mandatory. You can only call a RANO response if you see it in 2 scans at least 1 month apart. That's what we call a durable response. For progression disease, it's only mandatory to obtain confirmation scans in the 3 months after radiation completion. Of course, for tumors that do receive radiation. It is still suggested for immunotherapy trials where we fear that there can be some artificial enlargement that is due to the treatment rather than due to real progression, but it's still optional in all other cases if the sponsor mandates the confirmation scans for progression. Let's see how they work. If we see a progression, we call it preliminary progression in case we are required to use confirmation scans. And we only call confirmed progression if we see further growth from that time, whereas if there's shrinkage or stabilization or even insufficient growth, we call it a pseudoprogression PSP. The cutoff, again, is that 25% increase in bidimensional products or 40% segmentations. So here's an example where we measure the tumor, it is growing, then it's growing again, and we call it a confirmed progression, and we backdate the day of progression to the first instance of growth. Conversely, here there is a growth and then the lesion stabilizes, kind of shrinks back. That's what we call a pseudoprogression. A very important difference between these 2 cases is that this patient, after we confirm progression, we flag this time point as the progression date for RANO purposes, and at this time, after the confirmation, the patient exits the trial, changes the clinical management because this medication is not working well in controlling the tumor growth. Here, instead, we waited to obtain a confirmation and we did not obtain a confirmation. It's a pseudoprogression. It means that the patient stays on trial and stays on the medication that is experimental medication of the trial. So there's a difference in management only with the actual confirmed progression. Beyond radiographic reads, also clinical progression is considered a progression in RANO in terms of neurological status progression or performance status progression. And again, beyond the radiographic findings, something that we have to think about is corticosteroids dose. We know historically that corticosteroids can cause an artificial shrinkage in the contrast-enhancing tumor volume or tumor size. That's why with increased steroids, we cannot assign a RANO response because the shrinkage can be due to steroids. However, which is interesting, in case the tumor is growing, we still need that 25% or 40% volumetric growth even in case the patient received increased steroids, which is kind of counterintuitive because that competing effect of steroids in artificially shrinking the tumor may cause that tumor that still is progressing to not meet this pretty demanding threshold of 25%, which is a lot. And also, if steroids are decreased, there may be an artificial enlargement in the tumor, and that's why you cannot call a progression in case of steroid decrease. We kind of tried to address this issue of corticosteroids recently, and we tried to provide a quantification of how much tumor shrinkage of the contrast enhancing component volume we should expect from corticosteroids, and we quantified approximately a 44% shrinkage, ranging 60% to 25% after adjusting for interval growth. We do need more and more data to have actual benchmarks to know what percentage shrinkage is attributable to corticosteroids, but the final aim would be to have benchmark data so that we can adjust this cutoff. And if we know that a certain shrinkage can be due to steroids, then maybe we require a lesser increase to call a progression under steroid increases, meaning we get an adjusted cutoff for radiographic progression under steroid increase, possibly in the future. Let's move to BT-RADS, which is a system that is thought to guide and help in the clinical practice. It's based on a survey and on consensus of the physicians that participated in the survey, and they assign categories 0 to 4, like in PI-RADS. Importantly, it's qualitative rather than quantitative, meaning that you kind of visually see if the lesion is worse or better over time, although we'll see that there is some role for quantitative measurements too. And an important aspect of this proposal is to use structured radiology reports to make sure that you cover all of the important aspects. You can at least maybe take a look and use it as checklist that you included and considered all the aspects that they suggest. The first thing that caught my attention is that there is a BT0 class in case that's the first scan available. And then it's kind of not strictly defined, but it looks like you kind of compare everything else down the line with this BT0 scan, which is dramatically different from what is suggested in RANO 2.0. We saw how RANO demands a specific reference scan for progression and a specific reference scan for response, whereas here it's a bit more vague, where you just use that BT0 first scan that you have. I understand that this may be more suitable sometimes for clinical practice where it's not like a clinical trial where you have all the previous time points, maybe you have only some of them. But so this is a majority difference. I think that RANO 2.0 is a bit more convincing in this aspect, but I understand that sometimes you don't have all of the prior scans in a clinical situation. If the findings in the follow-up scans are improved, you have to check whether medications, and truly they mean steroids or bevacizumab, have been used, and then you can assign a BT1A class if there is no steroid increase, if the patient is on bevacizumab, but the improvement is seen for more than 4 weeks, or a BT1B possible medication effects, maybe meaning that the findings are improved, but it could be due to a steroid increase, if that's the case, or for a recent bevacizumab start. Compared to RANO, there are some similarities. You cannot assign the real response category if steroids have increased, and you have to confirm the response if bevacizumab was started, confirmation in 4 weeks, which is the same as the confirmation scan in RANO 2.0, essentially. There's a BT2 class for stable disease, and then if the findings are worse, you have to figure out whether more than 90 days have passed from the end of radiation. If that's the case, favored treatment class B3A, where favored treatment really means treatment effects, essentially, so that's the worsening can be due to the treatment and not to tumor progression. It's similar to RANO in the sense that they acknowledge this 3-month window after radiation that is at risk for pseudoprogression, but RANO handles this instance with confirmation scans instead of flagging a specific category. However, this B3A category results in a suggestion in BT-RADS to obtain a confirmation scan, essentially a follow-up scan before expected, which is the same as obtaining a confirmation scan. So It all goes back to a similar concept to RANO 2.0, where a progression in this time window requires a confirmation scan. So not that different. If more than 90 days have passed from the end of the radiation, you can assign BT3B or 3C, which are, in my language, for simplification, a marginal worsening of either flare or CT or contrast enhancing T1, or a worsening of less than 25%. Here you see there's a measurement. They don't really specify how to measure. I think that a RANO style bidimensional measurement would apply. And I do want to point out that less than 25 wars would not even be a progression in RANO, it would be stable disease. But then, more importantly and more interestingly, there is a BT4 highly suspicious for progression class that is assigned if the growth is more than 25%, which is essentially a RANO progression, or wars over two scans, which is essentially the same as saying confirmation scans in RANO 2.0. So again, to say there are some points of contact that I see between the two systems, even though they are meant for two different applications. Just like in BT-RADS or other RAD systems, when you come up with a BT-RADS score, there's a suggestion in the clinical management. There is no difference, and we're going to discuss this more later. There is no difference between improved or stable. The management remains unchanged if the tumor is improved or stable. So there's not really a need for us to get that specifically into whether something can be 1A, 1B, or 2, because really there is no pragmatic change. Something starts to change whether you flag something that is possibly worse. In that case, they suggest a decreased time interval of follow-up, which is essentially the same as in RANO 2.0, saying let's just use a confirmation scan to make sure that we are calling progression correctly. But then, more importantly, you only change management if you're sure that you're seeing an actual progression. In terms of validation, RANO has had extensive validations throughout the years. There's a lot of inter-reader agreement studies, and there's several overall survival validation studies, even in large multi-center cohorts. So it's a pretty robust system, largely validated. We see here the PFS and ORR from RANO. They are tightly linked with overall survival, meaning that they are reliable and they are validated in this sense. For BT-RADS, the validations are not really, so validation is a tricky term in this case. Let's just say BT-RADS has been shown to, in some studies, to improve the readability, clarity, and completeness of the radiology report. So it's kind of a communication endpoint rather than validity per se. There are some inter-reader agreement studies like these ones that are therefore more of a agreement studies rather than validation studies per se. In terms of validation, there's a true progression prediction study and some overall survival correlations, but they are still, I want to say, preliminary studies on small single center cohorts. So we definitely have, there's definitely room for more validation of this system and even possibly some changes down the road, just like RANO was changed multiple times over the years, and BT-RADS too have constant updates. So maybe there's going to be some changes in the future and some more validation down the line. So after we presented these two systems, I want to point out some concepts and strategies that I would adopt in the clinical practice. One thing that is so important, I think, is to understand that labeling progression is what really makes a difference. Labeling response versus stable disease doesn't really change the management of gliomas as of today, but labeling progression means what you essentially are doing is that you're telling the neuro-oncologist or the treating physician the current management is not working in controlling the tumor growth. Whether the current management is a wait and see strategy for a low grade, whether the current management is a chemotherapy or immunotherapy line for a glioblastoma, what you're saying is this tumor is growing. It is growing despite of the management or the treatment. So we need a different line of treatment and another radiation session or another cycle or another surgical resection. So it's important to understand that when we call progression, the patient will likely receive a new, different treatment. And we also have to keep in mind that for gliomas, especially for glioblastomas, there's not a lot of valid lines of treatment. So every time we declare that a patient fails a line, we are left with fewer and fewer bullets down the line to escalate and try new treatments. So we run out of treatments very quickly. So we have to be very mindful when we call the progression. I do want to point out that this concept that I just said, is valid now, but maybe in the future we can be more ambitious if we have new treatments that work better. It's already the case for other diseases. Let's think about cerebral lymphomas, where after the induction with methotrexate, whether you hit response or you don't hit response, you just hit stable disease, there may be a difference in how the maintenance treatment is done. So a concept that I liked from RANO 2.0 is to try to use the post-radiation MRI as a new baseline. Let's not look too much into the changes of pre to post-radiation, because there's a lot of pseudo progressions happening there, and there's relatively new data showing pretty clearly that the correlations between PFS and OS are improved when post-radiation baselines are used instead of pre-radiation baselines. I like also the concept of trying to be mindful of what reference scan we're using for progression definition. And we should try our best to compare to nadir. If we just compare to the previous scan, maybe we're not seeing that much of a growth, but then we go back and we look at the nadir and maybe we do see an actual growth, meaning that the tumor really restarted growing over time. Of course, I'm mentioning the nadir as like the tumor at its smallest size within the same treatment. Let's not go back and compare to the nadir of previous treatments 2 or 3 years before. Confirmation scans, as I said, is a concept that we can still use in the clinical practice. It is a very central concept in RANO 2.0, but again, we saw how in BT4 too, there's that concept of worsened over 2 scans, so very similar too, and especially early after radiation or for immunotherapy agents. Let's remember we have this option when we see a growth. Maybe we can wait to see if the tumor grows again, and only then we call a confirmed progression, and we suggest that the patient has to change treatments and change management. Whereas other cases, you may see a growth that then kind of stabilizes and shrinks back. In this case, it was a good thing that the patient was maintained under the same treatment because the lesion shrunk back autonomously. Again, let's remember about corticosteroids doses. We should always obtain information about corticosteroids and about the corticosteroids at previous time points, because we have to know the corticosteroid dose not only at the time point we are evaluating, but also the reference MRI scans that we're comparing against. We already saw and mentioned how there's this pseudo-response phenomenon, and I call it pseudo-response because it's a very similar mechanism to the bevacizumab pseudo-response. And you see after steroids, there's a major shrinkage sometimes of the contrast enhancing component. But I do want to point out that the issue is rather on the flip side of correctly calling a progression when the steroids are increased. So in this case, steroids got increased. The tumor is clearly growing because there's a new nodule. The tumor is overall larger, but if you quantify the contrast enhancing portion, you see that all of these nodular contrast enhancing tissue components are kind of gone. This is more thin, definitely thinner rim of enhancement out here. So overall, the quantification of the tumor volume grew only marginally. So this would not even be a RANO progression. But in the clinical practice, we may still integrate this information and say, okay, the tumor grew, there's a new nodule, and the patient received more steroids, so they probably counteracted the growth, and we should call cases like this as progressions. So we saw how the RANO 2.0 system is heavily measurement based, but the BT-RADS system is largely qualitative rather than quantitative, with some exceptions, as we said. So what should we do? Should we measure? What I think is that measuring is still very important in the vast majority of cases for 2 reasons. One reason is that we get an understanding of what degree of growth we have to observed to call a progression. And of course, these magical numbers of 25%, 40% volumetric don't really have to be used religiously in the clinical practice. You can also call a response with 20% or 18% or whatever if you're convinced that the tumor is growing. But this gives you an idea of the order of magnitude. So let's not call a progression if you still see, you eyeball and see a little bit of growth that quantitatively boils down to a 10%, 5%. Maybe it's not worth calling a progression. Again, as we said before, we should be mindful about calling progressions in these cases and really be sure about our decisions. And yes, it's a RANO concept to measure, but we saw also that BT4 class has that 25% threshold. So it's not a foreign concept to BT-RADS either. And then the other concept that it's not always considered is the concept of RANO measurable disease. So if a lesion is not RANO measurable, meaning that it's underneath 1 centimeter, maybe we just call it non-measurable and we wait for it to become measurable before we call it progression or a preliminary progression if we need confirmation scans. Because otherwise we get in a very awkward situation where very small lesions may grow very little, like 1 or 2 millimeters, and we do the math and it looks like a 70-80% increase or even more, and we are tempted to call that a progression, but clinically this doesn't really matter, and it could be noise or inaccuracy in the measurements, or partial volume effects or technical inconsistencies rather than an actual growth. So my suggestion would be, if it's measurable, remains not measurable, let's just call it stable disease, and only when we will become measurable, we will call it progression or preliminary progression. Lastly, I do want to say sometimes my faith in the measurements kind of breaks. And my favorite example is infiltrative disease. Even if you're segmenting, it's kind of approximative to define what is tumor and what is not in cases of highly infiltrative disease. Possibly in the future, there's going to be more and more AI segmentations. And even though approximative, maybe they're very consistent and you can clearly track over time if the tumor is growing or not, even if the segmentation are approximated. Even worse than segmentations would be to come up with bidimensional measurements for these cases. So I think that these scenarios really advocate for complementary qualitative assessments, meaning that you don't necessarily need to obtain measurements if you have other means to say reliably that the tumor is growing. So let's see this case where over time the insular cortex is becoming thicker and thicker as the sylvian fissure is becoming thinner. And the same we can say in the temporal lobe is becoming larger with more mass effect, more infiltration, and this ventricle is becoming thinner over time. So this tumor is clearly growing. We don't need to go in multiple slices and find ways to arbitrarily and approximately obtain measurements. I think maybe it would be even more confusing in this case. So extreme cases like this, I think we don't really have to do our homework of measuring necessarily. We can just describe what we see and call that the tumor is clearly progressing. Of course, we can only do this in the clinical routine. In a RANO situation, we would have to come up with some sort of measurements because that's inevitable in RANO. So again, this is what we covered during this presentation, and these are all pretty much all of the references that were included in the presentation, and that's all.